Hi, class. Everyone, welcome back to the part two of hypersensitivity. Now, this part is a little bit boring in a sense. So, if you are feeling sleepy, don't watch it right now. When you watch it, only when you are wide awake. Okay. Now, without further talking, let's go to the lecture.
Alright, let's come back to the part 2 of hypersensitivity. Alright, so this part 2 we will begin dive into talk about the details of type 1 hypersensitivity. Now, it is a immediate hypersensitivity, okay? This little flower really represents the central concepts of a lot of cases of type 1 hypersensitivity, i.e. allergic to pollens. Okay. Alright, type 1 reactions are IgE mediated. Okay, that is the key. IgE mediated. Let me switch to a pen. Look. Alright. And IgE are uniquely, quite unique, okay, among the immunoglobulins found. The main reason is that it is found in peripheral tissues, okay, rather than in the secondary lymphoid tissues and in the bloodstream, okay. They are still synthesized by plasma cells, and it requires Th2 cells input. Right, in a hypersensitivity reactions, really the type of antibody or immunoglobulins that is formed is IgE. Okay, that is really the major one during this type 1 reactions. Okay, and a little bit of these low dose antigens that are being introduced into the body that crosses the mucosal membrane, and that is really the first step to initiate the formations of IgE. Alright, let's take a look with a graph here to help us to see how this type of IgE formations are being happened in a way. Alright, so the initiations of this type 1 hypersensitivity really, it just looks like this diagram here. You inhaled some of the pollen that goes into your body. In a way, these sensitizations really, it's very similar to in terms of thinking of a bacteria going into your airway. Sorry. And these antigens actually roll along the epithelial cells of your airway, kind of roll, and really in the same way that's just like the bacteria that kind of roll, right? And then and what happened is that they will got broken into smaller pieces and then cross the epithelium. And at that time, antigen-presenting cells such as macrophages will go in and see these foreign bodies, will eat it up, and then process further, and then lead to activations, present the antigens, and then lead to activations of antigen-specific T cells. What is this? What is this? MHC2, right? Okay, so it is very similar to like eating up a bacteria in a sense. And in a sense, in order to produce antibody, okay, think back, we will need first we'll need some B cells, right? B cells, right, as indicated here. Right, so they go through the activations of B cells by Th2 helper cells. Okay, it will then lead to Th2 helper cells activating B cells, differentiate into plasma cells, start isotype switching and producing IgE, and IgE bind to the receptors, specific receptors on mast cells. All right, we'll look into those specific receptors in later slides. Alright, so here is the central message. Okay, type 1 allergic reactions are favored by Th2 cells activity and isotype switching of plasma cells to generate IgE. Okay, so this is a central message here. Now this diagram is in a line figure, but it's no difference than the other figure that you see in the adaptive immunity package there. Right, so here shows you the two sides of the story. Th1, leading favored macrophage activation, and Th2 favored the activations of particularly B cells and start producing IgE. Okay, so here is the Alright, let's look into some of the greater detail. Now, this is a little bit recap, okay, and maybe a little bit extra information in this topic compared to when we first talked about in self-care, when we talk about allergy meds, okay. Now, the IgE, in particular, the FC regions of the IgE, i.e. what? Okay. Alright, that's the FC, okay. The stem, you can call it stem, but it's not very scientific, but it looks like kind of like a stem. They will bind and very, very tightly to Fc epsilon receptors that are expressed all the time on mast cells and basophil. Right, constitutively means all the time. They are there all the time, and they bind essentially irreversibly means really just very, very, very tight. Okay, very, very high affinity. Okay, think it back in terms of those term affinity. All right, very, very tight. And then it will also bind to induced receptors, okay, that are on eosinophils. Okay, eosinophils normally don't have these Fc epsilon receptor, but through the activations by the cytokines, it will start having these specific receptor being released. Alright, so sensitization, i.e. the first exposures after the first exposure, the primary IgE responses, the allergens are being cleared from the systems, and here some of the excess will be staying on, okay, staying on these receptors, i.e. something like armed missiles, right? Remember when I first talked about it in self-care, I talked about it in terms of having it armed and ready to fire next time, okay? Alright. And these are quite stable type of a complex, primed, okay? Alright, so the unique features of these IgE or this receptor complex, have unlike B cells and T cells, the mast cells, basophils, and eosinophils are really immediately active after antigen binding. Now, remember when B cells and T cells, in order for them to work properly, they have to divide and differentiate, and then the clonal selections and all these things happen. Now, these cells do not need to do all these proliferation and differentiations. And these cells are also not restricted to a single antigen specificity, so they can carry multiple IgEs that are targeting for different types of allergens, essentially, right? So they can react to multiple different allergens, and also in terms of the result is that it will increase the variety of antigen sensitivities, so that person can be sensitized. So it's almost like once you've been sensitized once, and then it's going down the hill, almost sounded like, okay, and you can be sensitized with another one, and then the third one, and the fourth one. So that leads to multiple allergies. Some people are just allergic to a lot of things, because of this type of mechanisms. And after this sensitization, the next time you see this allergen comes in, it leads to very, very rapid degranulations of the mast cells, okay, and and that lead to release of what, histamine, right? So that you lead to all these type of symptoms, and it gets stronger over time, essentially. Sorry about that cough. And here is the graph to show you, what it means by desensitizations and how it happened. Now, here is the graphical situation, represents where first the antibody need to be interacting with the specific receptors, and this is a at rest stage, okay? But it is essentially primed, okay? It is primed with all these antibody. Now, when the antigens are being presented or being encountered by these primed mast cells, cross-linking between these antigens to the IgE will transmit signals, okay, that lead to release of preformed granules. Preformed granules contains histamine, okay, and other mediators of inflammation. Okay, it all comes out. Right, during degranulation, then you don't need to know the very specific details of what's going on in this figure. Just remember degranulations, a change in size, shape, and cytoskeletal, or regonization is occurs. So they need to somehow wiggle around a little bit, to squeeze out, in a way they can think of it's squeezing out these granules coming out, and mostly the major thing is histamine. So we're going a little bit faster here because I feel like these informations are somewhat old information with a little bit new message there. So mast cell, basophil, and eosinophils, they are packed with granules, and in particular the mast cells is packed with histamine, okay? And when the IgE and the receptor complex on the mast cell surface encounter the second allergen, the allergen in a second time, these release actions would be very quick, i.e. degranulations. Right? So these are some of the repeated informations there. Right, basically I talk about all these cross-linking and degranulations in the figure before that, so I won't go try to repeat these. Alright, so what I presented here is a little bit of a recap of informations, right? Remember we talked about before in the self-care. Again, I keep referring to self-care because it is really the second round in a sense. Well, there are two types of mast cells, the mucosal mast cells. Alright, so they are residing in the mucosal, near the small capillaries and veins like that, and we have the connective tissue mast cells which contained chromotryptase. Alright, here is a table. Okay, again, I show you all these table not not for you to memorize it, but for you to have all this information being grouped into a nice format. So again, I developed these from a textbook, and these it contains these red box here are those preformed preformed molecules in the mast cells. Right, it contains tryptase, chimeras, a lot of different enzymes, okay, and particularly the toxic mediator here we have histamine, right, and heparin as well. We didn't talk about heparin very much in here, but just FYI informations here. And also the TNF alpha here is both preformed and also induced. Okay, TNF alpha is both preformed and induced. Now the biological functions here are listed clear here. I won't just read it out to you. You can take your time to read about it. Okay. Alright, so these mast cells contain granules which have chymotryptase, tryptase, natural protease. These are all combinations are protease. Okay, what do they do? Right, so these compounds actually can contribute to remodeling of your extracellular matrix. So what does that mean? Now, normally most normal vertebrate cells or most cells cannot survive unless they are anchored to a extracellular matrices. Okay. Oh, sorry. Let me change back to my pen. So extracellular matrices here, we have our cells here, and the basement membranes, right? Okay. And then the other connective tissues down there. So these protease will break down these extracellular matrices, okay, making these things to lose support and falls off, or being swept out. So these actions are, also will cause inflammatory responses. So these actually initially could be a protective mechanisms because these are potentially helping off to clear all these damaged cells or some of the irritations along the airway. But on the other hand, chronically, if these things keep happening, these destructions of extra cellular matrices are continuous to happen for a long time, all right, chronically, it could be destructive because it would be leading to extra tissue damage. All right, matrix degrading, cell keep dying, and really don't get a chance to recoup. Okay, this will eventually lead to some of the airway obstructions that are found in some of the asthma patients. Okay. Alright, histamine. Alright, histamine here is the molecule for histamine. I won't ask you to memorize histamine molecule, but here again a little bit recap of what we've learned before. So there are 4 types of histamine receptor, H1, 2, 3, and 4. And in terms of the acute allergic responses, mostly are H1. So you've learned about a lot of those H1 blockers. Okay. And in terms of other receptors here, H2 you will learn it very soon in the GI modules. Okay, H2 are mostly in the GI, so I won't go into too much detail of it. Like other things that are being induced and also preformed. Okay, preformed mast cell granule contain these things are these TNF alpha. Okay. Now, it have a complement actions of histamine, i.e. they will contract these endothelial cells and also increase expression of adhesion molecule. These, also promote attractions of leukocytes to the inflamed tissues. Okay, so, and these features are quite unique to mast cells, the ability to store and release TNF alpha on demand. So these are all lead to basically inflammations down the road. Again, more inflammations. Okay, induced mediators, so chemokines such as CCL3s. Okay, promoting changes in vasculature bed and make it more sticky, leaky. Cytokines IL4, TNF alpha. So okay, all these are being important. Now, particularly IL4. Remember, it is more irresponsible for the T cells into differentiate into Th2 helper cell, which stimulate B cells and plasma cells, MA cells, and in the IgE. All right. Okay, so it will also induce mediators of other inflammations mediators, okay, such as prostaglandins, PGE2 and PGD2. Right. So these will promote dilation of blood vessels, increase permeability, chemotaxis of neutrophils. So these properties of prostaglandins, we've seen it before. And also there's another branch, leukotriene. Okay, it will also induce vasculature permeability, smooth muscle contractions, leading to all types of symptoms. Okay, shortness of breath, increase secretions of mucus. Okay, coughing up sputums, and having more runny nose, and such cases like that. Alright, so here is the graph recap, okay, about this, pathway that breaks down arachidonic acid. Alright, remember here we have the cyclooxygenase and the lipoxygenase. So we talk about this when we talk about NSAID drugs, okay. Alright, and then you will learn more about lipoxygenase pathway and the drugs that are mediating in this category when you start learning the respiratory disease modules. Okay. Alright, so we are still talking about type 1 reactions. Okay, we haven't moved away from type 1 reaction. Just a little bit recap here. So moving on to eosinophils and basophil. Remember, mast cells, eosinophil, basophil. Okay, so we are moving on to different type of cells. So similar to mast cells, these are specialized granulocytes that release toxic contents in response to IgE binding. Okay, and the preformed type of mediators are very toxic, and they are responsible for mostly for killing. Okay, killing invaders. Okay, and the induced mediators are usually responsible for sustaining or amplifying inflammations. Right, so these colors, don't worry about that, those stain with acid dye eosin, so that's why it's called eosinophil. Okay. Alright, so these eosinophils are resident in the tissues, okay, connective tissues underlying epithelial, respiratories, and GIs, and urogenital tract, and they are very low level in the circulations. Okay, if you remember the AMP lab in blood, last year, long time ago, we look at smears, smears, and it's hard to locate eosinophil because they're all in general very little in the circulations and what you take from the blood. Alright, so they are often recruited to sites of parasitic infiltrations or allergic reactions. So these are some of the recap information. So I won't go into much detail. Okay, parasitic kills parasites and also lead to expel parasites. Okay. Again, this table is similar to the last table where these red, pink type of boxes are the preformed content, okay, and the white one are the induced mediators. Okay, so the toxic effect, first, to be toxic to protozoals, okay, parasites, okay, they are not that toxic to us at the beginning, but eventually, if these levels are high enough, right, collagenase, okay, it will break down our collagen as well. Okay, but it's just not so much at the beginning. Alright, remember we talked about how the preformed granules of eosinophils are toxic and mostly for killing. So let's look at some of those examples of it. Now, first of those being major basic protein, or MBP. Okay, MBP is a toxic to a wide variety of cell type, but how it worked we don't know exactly, but it's disrupting the lipid bilayer or changing the membrane permeability to ions and make them a little bit leaky, and then kills of the cells. Okay. And the second one is eosinophil-derived neurotoxins, or EDN. Now, EDN actually is a ribonuclease 2. Okay, ribonuclease actually has antiviral activities against both respiratory type of viruses and HIV viruses in vitro in a dish. Okay, inside the cell, it's inside the body, it's a different story. Right, now we have the third one of these preformed content is the eosinophil derived cationic protein, or ECP. ECP, okay, here ribonuclease 3. This one have activity, cytotoxic activity toward bacteria, protozoa, and other type of helminth in vitro, and they can also regulate fibroblast activities and modulate airway mucus and all these type of a feature there. Alright, since eosinophils are kind of detrimental in a way, there should be ways to keep in track of it. Now, in the normal situation, there are very low level of synthesis of eosinophil in the bone marrow even, but upon antigenic or allergenic stimulations, the fluid activates the Th2 helper cell, IL-5, and other cytokines. It will stimulate its synthesis in the bone marrow, leading to increased productions and release of eosinophils from the bone marrow. Now, and then after its release, and it will need to migrate into peripheral tissue. So these chemokines, okay, these are having specific names. You don't need to memorize specific numbers or anything, in my opinion. So these chemokines, okay, attract eosinophils and also bind to the CCR3 receptors on eosinophil surface. Alright, so this in terms of this CCL11 eotaxins, okay, it's being produced, okay, and released from activated monocytes and endothelial cells, and that plays into a role into on the eosinophil actions there. Alright, so since eosinophil, it could be problematic, so it really need to be very tightly controlled in a way. So in the basal stage or resting stage, there are zero level of these Fc epsilon receptor expressed on eosinophil surface. So no receptor means no IgE binding, and no IgE binding means no degranulations. Now remember, abnormal degranulations can lead to all kinds of problems. You don't want unwanted remodeling of the extracellular matrices, and you also don't want too much toxic type of cytokines and chemokines being released. Okay, so the granulations can only occur when there is a induced expressions, subsequent to chemotaxis and by other compounds such as this eotaxins. Okay, now it has been shown that abnormally high level of eosinophil or abnormal activations are some of the contributing factors to some of the severe cases of asthma. So by learning this, basically you would be very well equipped to understand asthma. Okay. So high level of eosinophils are a characteristics of chronic inflammations, such as chronic asthma. Okay. And localized allergic reactions really are caused by accumulations of these eosinophils. And all these type of chemokines and all these attract eosinophils, and here basically it's a repeated inflammation, and all these bind to CCL3 receptors on it and causing it to eventually releasing more of these necrotic factors, and they are the principal cause for airway damage. Alright, again, I said it again. the chronic asthma. So I was ahead of myself. Alright, so here is just a picture showing you some of the differences between a normal lung biopsy or normal airway compared to people with chronic asthma. So chronic asthma is characterized by airway remodeling. Here shows you how this airways are being thickened, increased collagen depositions. Okay, so this is way thicker than this. So you have what? You have a thicker surrounding tissues, i.e. you have a smaller lumen, smaller airways, okay, that are not very suitable for, not very optimized for breathing in a sense. Alright, so after eosinophil, let's move on to basophil, okay? Basophil are also specialized granulocytes that release toxic mediators in response to IgE. Okay, like mast cells, the granule contents are similar to mast cells in a sense, and also the receptors, the Fc epsilon receptors for IgE are also constitutively present. On the other hand, it also have some resemblance to eosinophils. Okay, they are active against parasites. They are, synthesis is stimulated by IL-5, and they are also recruited to allergic reaction sites. So under normal circumstances, again, basophil are present only in circulations. All right. So here are some of the recaps. Alright, basophil's role. So again, here I am showing you a graph of that comparison between the Th1, Th2 type of differentiations. So during a innate immune responses, and basophils are recruited to infected sites where they are activated through the toll-like receptors, okay, and other receptors of innate immunity. In infected tissues, and basophil also contributes effector functions similar to those of eosinophils, i.e. doing some of the killing actions. Alright, so activations of toll-like receptors can trigger the secretions of IL-4 and IL-13, and particularly IL-4 here, also in resonance here, can favor the Th2 formations. Remember, it always ties back to Th2, right? Because I tie back to Th2, and then it will lead to more favorable release of IgE development. Right, so on top of the interleukins, there are also CD4 ligand on basal cell surface that can interact with CD40 ligand, interact with CD40 receptors on basophils. Okay, that also lead to contribute to the isotype switching to IgE. Oops. Alright, so here is a very complicated graph, but it's a good graph that it's quite old, okay, quite old already. Not a lot of new development in immunology, essentially. This is from Nature Review. Okay, this graph really summarizes everything back into one graph of where or what things are doing what in terms of all the mast cells, basophils, eosinophils, and how B cells being stimulated by Th2 cells and all these. So everything back into one page to show you about these allergic reactions. Alright, it is question time again. And who wants to be the millionaire? Now, don't mistake it, no one's gonna become a millionaire by the end of this lecture series. I think it's just a fun game to play. Well, the first part, you guys went through this $100 questions, okay? Just a little bit recap, okay, which type of hypersensitivity is not caused by antibodies. And you guys picked type 4, okay, that is correct. Now move on to the $200 questions. Which immune cell is not related to type 1 hypersensitivity? A. Mast cell, B. Th2 cell, C. TC cell, and D. plasma cell. I'll give you 5 seconds this time, okay? 1, 2, 3, 4, 5. Alright, do you have a final answer? Are you sure? Are you sure it is... what? C? Alright, final answer? C. Cytotoxic T cells. Okay, cytotoxic T cells are not related to type 1 hypersensitivity. Alright. Congratulations, you've won $200. And let's move on to the $300 questions. Which Ig is associated with type 1 hypersensitivity? Now, it is all related to type 1 hypersensitivity as a recap from the earlier lecture. A. IgA, B. IgE, C. IgM, and D. IgG. Alright, what is your final answer? This one I don't think is that bad, right? Alright, so you're very quick. You said it. Alright, let's look at it. It is IgE. Alright, good job. Well, now let's move on to the $500 questions. Alright, which cell type has inducible Fc epsilon receptor? Now this one look, testing you if you are paying attention to my talking. Alright, first choice is mast cells. A. B. It's basophil. C. Is eosinophil. And D. Lymphocytes. Alright, so which one has inducible Fc epsilon receptors? I'll give you again 5 seconds to think about it. Is it too quick? 10? I think 5 is enough. 1, 2, 3, 4, 5. Alright, I think you got it. But are you sure? I don't know. Are you sure? Okay. Are you sure? Okay, let's look at it. Alright, the answer is C. Eosinophil. Congratulations, you've just hit the 500 mark. Alright, well, let's continue more with our part 3 for the next time.